Hello, I'm Toni Roman, physiotherapist, osteopath and non-invasive neuromodulation expert. I'd like to explain the case of a patient with a cervicogenic headache, primarily painful at the orbital level. Normally, we can reproduce cervicogenic headaches during a session by stressing the joint when caused by some fascial issue or stressing the disc when caused by a disc or at a muscular level. So why does a headache occur at a supraorbital level when the problem is at a cervical level? The problem is basically that the cervical affectations, which would be non-susceptible stimuli, are linked to the trigeminal nerve through the cervical trigeminal complex. Through this complex, upper cervical affectations, C3, C2, C1, will be reflected at the orofacial level. In this regard, almost always at the ophthalmic branch. This patient will therefore have facet involvement of the upper cervical area at C2 on the left side, but this will be expressed with a supraorbital headache in relation to the supraorbital branch of the trigeminal ophthalmic branch. At this point, we've said that we would do a compression test, Sperling's test. Let's explain a little bit about the approach and treatment. There will be different implications in terms of neuromodulation. We'll place a central electrode to be used with program 1 to prepare the patient and also stabilize the patient's autonomic nervous system. Subsequently, we'll also work with an electrode on the ophthalmic branch. Let's place an electrode centrally at C7. We'll then put a second electrode locally at C2. C2, C3. Subsequently, we'll put a third electrode at the level of what would be the supraorbital branch of the trigeminal ophthalmic branch. So what will be our approach? We'll set program 1 centrally at C7, and from this first approach, we'll do cervical work mechanisms at the level of inhibition of the supraoccipital musculature. Muscular dissociation work, separating paravertebral structures from spinous processes. In this case, we have joint convergence component that facilitates the process of affectation. In short, the facetal process would be the cause. Rather than generating convergence mechanisms, we'll facilitate joint divergence mechanisms, and we'll do so from the contralateral side. New joint divergence mechanisms to allow facet separation, facet mobility in the opening. And from here, we'd also move more to the level of the local Nesa application. At the local level, we'll consider application of program 3 at the affected structures, downstream structures of the muscular structure. That's right, all the posterior muscular structures. We'll set program 3 for some 15 minutes, and then we'll continue to generate this traction work. Stripping these facets, mobility work, always within limits to ensure the patient doesn't feel any pain while we're doing this. We can do muscle stretching work. An important element is to move directly to what would later be metameric treatment. So what's that? Well, we'll go to the supraorbital area and place the electrode at the supraorbital level and work on program 7. We'd leave program 7 here to optimize the neurological resources of the autonomic nervous system. From here, we could work passively. In other words, the application of program 7, leaving it for 50 minutes after the local application, and we'll apply the electrode to the supraorbital branch of the trigeminal nerve or ophthalmic branch. And from here, we do a passive treatment with the patient basically stretched out on the table, leaving 50 minutes for the autonomic nervous system to neuromodulate in a relaxed way. Thank you. I hope you liked it, and I look forward to more videos explaining other pathology types.